19, I'm not sure, which is correct. But thank you very much for the invitation. I would like also to thank the organizing committee of the Congress. And of course, I'm not Stamatia Magiria. You can see it because this refers to a female name, and I'm not obviously female. But I will try to cover a little bit the topic of treatment guidelines. And these are my disclosures. And luckily enough, we are in an area called Pamphylia by Herodotus, and it is near Cilicia and Lycia, and this is Pamphylia, which means actually mixed tribes. A lot of tribes, different races, conquered the area and lived here through the centuries. And actually today we are going to talk about the treatment of a very mixed situation, which is bipolar disorder. And it is a mixed situation because unfortunately not even the diagnosis and the terminology is clear enough. Moreover, the treatment is not clear enough. And let's see a few things about the diagnosis. And there's a fight between the two major diagnostic systems, ICD-10 from the one hand and the DSM-5 now from the other hand. And there are some examples of this fight, for example, the mixed episode case, because as you know, the ICD-10 demanded overall the coexistence of or rapid alterations between manic, hypomanic and depressive symptoms in order to diagnose a mixed episode, whereas DSM-4 demanded the coexistence of a full-blown manic and a full-blown depressive episode. Unfortunately, this wasn't resolved until this year, in May this year, when DSM-5 was published. And what DSM-5 did was to erase the diagnosis of the mixed episode and to add a specifier, this specifier called with mixed features, which can be added in a manic episode, a hypomanic one, or a depressive one. So this diagnosis matter was resolved, but what about treatment? And what about treatment guidelines and the everyday clinical practice? So we are going to see a fight between the strictness of the guidelines and, on the other hand, the looseness of the everyday clinical practice. So there are many guidelines available today, but I will focus mainly on the WF-SBP guidelines because I do think that they are the most evidence-based ones. On the other hand, for example, the CANMAT guidelines are the least best evidence-based guidelines containing almost everything. But when you do read the guidelines, you may see some interesting data, some interesting things, that the more the pages the guideline will have, maybe the less data the guideline will have, and this is a paradox. But I can talk about this a little bit more, because let's take the example of the WF-SBP guidelines, and you see here that mania guidelines and depression guidelines, they are almost about 30 pages each, and they have to say many things. The problem is that the maintenance guidelines, that they do not have anything to say because we have limited data on maintenance of bipolar treatment. They are on 66 pages. And a few things about mania. If you read the WF-SBP guidelines, you see that they divide the available treatments according to standards, the category of evidence, and the recommendation grade, and you see here that we do have almost all antipsychotics with a category of evidence A, the higher category of evidence. Some of them, due to tolerability reasons, are not graded as 1 in the recommendation grade level, but as 2, etc. And also we do have valproate and lithium, for example, from mood stabilizers as efficacious anti-manic factors. On the other hand, regarding acute bipolar depression, and we will see later that the case of acute bipolar depression, according to the guidelines, is very user-friendly. In the what I mean is that the clinician is always right. And why is that? Because everything he can do is within the guidelines. The guidelines contain everything. And Finally, these are the maintenance treatment guidelines, whereas with the exception of here, if you see quetiapine, which is recommended at first place for all the spectrum of bipolarity, meaning manic episode, depressive episode, or maintenance treatment, then we have sporadic drugs like here aripiprazole for the prevention of manic episodes, lamotrigine, the prevention of depressive episodes, etc., etc. So there are a lot of uncharted areas regarding the treatment of bipolar disorder. And I'm going to talk about pharmacoepidemiology. And pharmacoepidemiology is actually the merge of two different sciences. On one hand, we do have the pharmacology. On the other hand, we do have the epidemiology. And what pharmacoepidemiology can say to us is how the everyday clinician, the everyday psychiatrist treats the bipolar disorder. What drugs do we use in our everyday clinical practice? And pharmacoepidemiology also can give us crucial data for exploring various aspects of medicine and of the use of psychotropic drugs like efficacy, tolerability, safety, economical matters, etc., etc. And if we can say it in other words, if the treatment guidelines represent a form of evidence-based medicine, then the pharmacoepidemiology studies represent a form of medicine-based evidence, because they teach us how the everyday psychiatrist can, by using his clinical wisdom and knowledge and experience, treat the bipolar disorder. What do the previous pharmacoepidemiological studies say to us? They do say that many, many years ago, when even not official guidelines existed, but mainly experts' opinions existed, then the clinicians rarely followed these experts' opinions. And what happens nowadays, this is what I'm going to say to you now. Although we should keep in mind that not following the rules, like guidelines, is inherent to human nature. Take, for example, these guys. These are two officers in the United States, and you know how strictly is the smoking prohibited in the United States. And these officers work for the TSA, which is the agency which allows you to enter into the United States, but they do smoke in a designated no-smoking area. And also, for us as clinicians, it's very difficult to follow the guidelines because we must follow a chart like that. And this is not something that we can do in everyday clinical practice. It's a little bit of confusing thing because it is like to try to find your way to the orange line by following the arrows showing you the green line. And this is, as you understand, confusing. What about the acute mania? First of all, the data are limited. Secondly, in 1970s, back then, the era that me and my wife were born, the clinicians mainly prescribed first-generation psychotics, but not lithium. And you know that the 70s fashion was a little bit peculiar, and you remember this pop group from Sweden, the ABBA, and this not so good and fancy shoes and trousers for men and miniskirts for women and beards. And some years later, in the 80s, the fashion changed, and you remember maybe Dynasty, which prevailed, and fancy and very heavy dresses for women, clear faces for men. But unfortunately, the prescribing patterns didn't change. Although there was a slight decrease in the prescription of antipsychotic monotherapy, there was a slight increase in the prescription of antipsychotic plus lithium or carbamazepine combinations. These combinations were still not widely accepted. So, in the 1990s, and this is data from Brazil, still first-generation antipsychotics were the most highly prescribed medication in acute bipolar mania, but lithium here, carbamazepine and valproate started to gain some prescriptions. And this also is true, and it is shown nicely here from a recent paper which recorded the patient data from 531 bipolar patients in acute mania, and they divided the data from 1999 until 2003. This is the first set of data, and the second one from 2004 until 2007. And you can see here that within these years, nicely, the prescription rates of combinations between immune stabilizer and an antipsychotic increased significantly, and the valproate prescriptions also increased. Carbamazepine here decreased, quetiapine increased significantly, and olanzapine decreased, although not significantly, mainly because, maybe because of the metabolic syndrome case. And this data is also confirmed from a UK study from London in 2004. 70 acute manic patients were analyzed, and you can see here that within the first day of their admission into the hospital for acute mania, they all received mainly a second-generation psychotic, and on discharge they received, the majority of them, almost 50%, a combination of mood stabilizer plus an antipsychotic. A very interesting finding from the pharmacoepidemiological studies in acute mania is a paradox finding, because you can see here that there are patients, and this study came from France last year. It analyzed 600 acute manic patients, and we saw that almost 12% of acutely manic patients received an antidepressant. They were not manic enough, maybe. And the third of hypomanic patients received an antidepressant. And 63% of mixed episode patients received, while in mixed episode, an antidepressant. And 5% of them as monotherapy. So the things about acute mania is more or less clear. You see that they are increasing the combinations, the prescription rates of combinations between immune stabilizers and antipsychotics. But in real life also the messages sometimes are very clear. And this is a picture from, I'm sorry to say it, but it's a toilet, which it says here that if you do this, you may suffer this penalty. And this is very clear, no doubt. On the other hand, the guidelines and the treatment guidelines for bipolar depression, it is not so clear. Although earlier I told you that they contain everything. And this is the problem, that they contain everything. And this is a synopsis of the treatment guidelines in acute bipolar depression. And you see here that everything you do, it is within the guidelines. So the guidelines in this case did not guide you anywhere. And on the other hand, pharmacoepidemiology is very clear in acute bipolar depression, because it says that the majority, the vast majority of patients, of depressed bipolar patients, will take more or less an antidepressant. And this is true whenever you look at the data for the 80% of patients. An interesting finding from this study with more than 2,000 bipolar acutely depressed patients is that 20% of them received venlafaxine. And for many clinicians and researchers, venlafaxine is considered to have a deleterious effect regarding the switching of polarity in bipolar disorder. Although this effect was not proved to be true by the STEP BD study, for example. And some data from our hosting country, from Turkey. In Turkey, as you know better than me, in 2003, the guidelines for bipolar disorder overall became available. And Turkish colleagues saw how these guidelines affected the prescription pattern, the prescription habits of Turkish psychiatrists in bipolar depression. And what they found was that only in the most severe form of acute bipolar depression, which is the bipolar depression with psychotic symptoms, the clinicians followed the guidelines. And what about the maintenance treatment? We saw that acute mania, the guidelines are pretty clear. The data from pharmacoepidemiological studies is becoming more and more clear. On the contrary, in acute bipolar depression, guidelines are not guiding anywhere, but the pharmacoepidemiological data is very clear. And what about maintenance treatment? Do we know something even from the literature? And can you conclude something from our habits, everyday habits? And in order to answer this question of what we do know about the maintenance treatments or what do we not know about the maintenance treatment, I will use a phrase from this guy here. This is Donald Rumsfeld, the Secretary of Defense, who served under the presidency of George W. Bush, who, in a similar question, gave a very simple answer. And I'm going to use this answer. He said, there are known knowns, there are things we know, we also know there are known unknowns, that is to say, we know there are some things we do not know, but there are also unknown unknowns, the ones we don't know, we don't know. And I should conclude with this phrase because it contains everything. But I didn't understand what I said, so I may continue with a few more slides. And what about the maintenance treatment in the past? Of course, in the past, antipsychotics prevailed, and it was the mainly chosen drug for maintenance. And nowadays, what are the things, how are the things going? And let's see the case of lithium. And we'll separate the east part of the Atlantic Ocean from the west part of the Atlantic Ocean. First, we will see the situation in Europe, and in Europe we see several different trends of prescribing patterns regarding lithium. Here is Great Britain, UK, with the highest prevalence of lithium usage among bipolar patients, and Spain, on the other hand, it's only 7.9 per 10,000 persons, but it is a percentage which slightly increases year by year. From the other side of the Atlantic, the data also varies a lot because you can see here that there are studies talking about 8 out of 10,000 persons who use lithium until, and on the other end, 50 among 10,000 persons who are being prescribed lithium. And STEP-BD study showed that younger patients, almost 40% of younger patients were prescribed lithium, and the older patients in a percentage of about 30% were receiving lithium, but the prescriptions of lithium in the United States are falling. And what about the debate of mood stabilizers versus antipsychotics? We will start from the reverse side of the Atlantic now, from the United States, where they tend to use more mood stabilizers, as STEP-BD study showed us, than antipsychotics. Although, I should underline here that only 10% of patients are under monotherapy with mood stabilizers in the United States. On the other hand, we can see the data from UK again, which is more balanced. Half of patients take mood stabilizers, the other 50% second generation antipsychotics. From Germany, what about the debate of monotherapy versus polypharmacy? And you see here this data, which data is a little bit misleading because the most of these 300 patients who took part in this cross-sectional study were bipolar 2 patients and non-bipolar 1. So the majority of them were under monotherapy, and the most commonly prescribed drugs were, what else? Antidepressants. Combinations were more common in patients with rapid cycling or mixed episodes. And also some data from the United States on this topic of polypharmacy against monotherapy. And you see here that a significant percentage of patients, again, are receiving monotherapy, but this percentage is shrinking because the most preferred strategy when the patient doesn't do well on monotherapy in maintenance phase is to add another antipsychotic, another antidepressant, another mood stabilizer, than to change, to switch the monotherapy. So this leads to a shrinking percentage of patients under monotherapy. And STEP-BD showed these things because, as I mentioned earlier, only 10% of patients were under mood stabilizer monotherapy. And some more data about polypharmacy, which is becoming an increasing percentage, a more favorable trend for clinicians. And this data analyzed more than 13,000 visits among 10 years of bipolar patients to their doctors. And you see here that the percentage of patients within 10 years taking at least 2 different psychotropic drugs was increased. But here is the most important element of this study, which showed that the percentage of patients taking 3 or more psychotropic drugs within 10 years was doubled. And all this data about maintenance treatment, first of all, that antidepressants is the most commonly prescribed category of psychotropic drugs. Second, that polypharmacy is more common situation than monotherapy, where also these two conclusions were also presented by Baldasarini and colleagues, who studied the records of more than 7,000 bipolar patients, and they showed that initially and 1 year after, 70% of them they were receiving antidepressants, while at the same period of time the percentage of patients under monotherapy was reduced by half. And moreover, this is a more recent study from Canada, shown here that in this study population of more or less 100 bipolar patients in maintenance phase, their records were analyzed, showing to us that the majority of them were, whether they were under the diagnosis of bipolar I disorder or they were diagnosed as bipolar II disorder, they were under treatment with antidepressant. And most interesting finding in this study was that when in this period of time these patients became hypomanic, either bipolar I patients or bipolar II patients, the majority of them continued to take an antidepressant. So conclusively we can say that clinicians do not always follow the guidelines, but you can see here that they are more and more close to them. Of course we have exceptions, and one exception is the fact that antidepressants are the most, or the second most frequently prescribed category of psychotropic drugs, and on the other hand patients receiving monotherapy is a shrinking minority. There is a shift in acute mania towards mood stabilizer plus second generation psychotics combination, and I do think that if the scientific community can produce more user-friendly guidelines, this may ease and expand their usage. So with this picture of my hometown Thessaloniki after a rainfall in the autumn, I would like to thank you very much for your attention. Thank you very much.